I would like to take just a moment to introduce folks at the Association of State and Territorial Health Officials. This is a very strong organizational partner with our office, and we've seen them do some really great work independently as an organization, but also with their members to encourage their health officials all across the country to get more engaged. And so really want to thank Christi, Mackie, and all of her colleagues at ASTHO, along with their members. And very excited to hear from Joan Duwve as well. So Christi, you want to kick it off?
Great. Thank you so much, and thank you for the opportunity to speak today. Again, ASTHO is a membership organization serving state and territorial health officials. We see them as the primary public health strategists within a state, somewhat like key public health influencers. And not only is it, public health officials that we serve, we also, take into account their principal leadership teams and support their public health agencies as a whole, working from that perspective as an agency-wide perspective. So today I just wanted to take a couple minutes to talk about a resource that ASTHO's developed. It's really intended to bring together state efforts across government, thinking about partners that can help us address the epidemic from a comprehensive, multi-sector approach versus just focusing in on providers, the delivery system, perhaps even enforcement. We call the resource ASTHO's National Framework for Opioid Prevention, and I'll talk a little bit about that in a couple minutes. Next slide, please. So, bringing this back to prevention and the work of prevention, oftentimes when we talk about prevention, we don't always mean the same thing. So there's a difference in the language that can be problematic. As an example, are we talking about overdose prevention and naloxone? Or, perhaps overdose is a little late in the cycle. It's still extremely important, but we're thinking from that prevention standpoint, we need to move upstream. Next slide, please. Taking a look at, is it moving to the next slide? Sorry. Taking a look at prevention, also back to this language piece, are we talking about prevention as, are we going to address the opioid supply, such as, prescription monitoring programs? Perhaps it's not in this space alone that we're going to be effective, just because we think of this, the vector here is not, the vector within the epidemic is not just prescribers, and we need to look at this a little bit more comprehensively. Next slide, please. So thinking about primary prevention, really looking at the misuse from the beginning, so trying to prevent that piece. We do know that there's a lot of promise in this space around primary prevention, but we just don't have a lot of evidence at this point. Next slide. So this particular slide is a pyramid that represents a three-tiered approach to the issue, and it doesn't focus on one single drug. I'm not sure, is the slide progressing?
Christi, that was the last slide from your set, preventing opioid misuse?
Oh, no, it was, there's one before that. I'm sorry, there's a lag here. I don't know if I'm seeing that. Okay, this is where I'm talking. So this is a pyramid, just, really quickly, that represents this three-level approach that I just spoke of, and it doesn't focus on one single drug, and it doesn't really take a look at one single approach. So looking at this comprehensively from a primary, secondary, and tertiary prevention approach. And really, this is, we're looking at 5 key goals here, looking to reduce stigma and change those social norms, increase protective factors and reduce risk factors within communities, strengthen that multi-sectoral approach, taking a look at the collaboration, and also improving prevention and that infrastructure, and taking a look, sorry, I'm working from home today, and taking a look at cross-sectoral partnerships. Next slide, please. So this, I mentioned a little bit about this and this resource, and what it is ASTHO's National Framework for Preventing Opioid Misuse and Addiction. This framework is really a comprehensive multi-agency approach to assist agencies to respond to the opioid epidemic. It's a website, it's comprehensive, it's interactive, and it's pretty much a clearinghouse of information and programs that we've assimilated, collected, and housed on our website. And it's really intended to reduce and control access to opioids, improve access to the use of and effective treatment and recovery support, improving monitoring and surveillance of the use of legal and illicit opioids, expanding and strengthening educational strategies, and expanding evidence base of effective prevention and treatment strategies. So this framework is really intended to be an opportunity to help lead state public health responses to the opioid crisis. It's a way to align work across states and regions, an opportunity to expand multi-sector collaboration around substance abuse and working with substance abuse and addiction agencies, healthcare delivery systems, law enforcement, amongst many others. And it can be used also as somewhat of a checklist to kind of balance or, check yourself or check your state efforts and their response plans to identify any gaps in planning. I'll go ahead and chat in the website on the chat box when I'm done, but right now you can find that at my.astho.org/opioids. And with that, that's our last slide. I'd like to introduce one of our members. Her name is Dr. Joan Duwve, and she is with the Indiana Department of Health.
Hi, thank you, Christi. Can you all hear me?
Yep.
Okay, great. And thanks to Corinna and the folks at HHS for hosting the webinar, and for Christi and my colleagues at ASTHO, in particular my colleagues on the Infectious Disease Policy Committee, for inviting me to join them today to present to you all. So I'm going to present a model of effective community-based services for the prevention, diagnosis, and treatment of both HIV and hepatitis C. This was developed during the HIV response, the HIV outbreak response in Scott County, Indiana. Next slide, please. In December of 2014, 3 individuals from the small rural community of Austin, Indiana, which has a population of 4,200, were diagnosed with HIV. Our disease intervention specialists learned that 2 of these individuals had a common needle-sharing partner, and HIV was then quickly diagnosed in 8 additional people through contact investigation. Only 5 HIV infections had been reported in Scott County during the entire previous 10 years, so this was an ominous sign. The source of HIV transmission, we learned, was injection of the prescription opioid Opana-ER. And as of January, 228 individuals have been linked to this outbreak and tested positive for HIV, nearly 95% co-infected with hepatitis C. Next slide, please. Indiana, like other states, has seen an overall increase in rates of hepatitis C over the past decade. As you can see from the map on the left, between 2012 and 2016, nearly all Indiana counties experienced an increase in rates of hep C, with more than a third experiencing greater than a 100% increase. When we look at hepatitis C diagnosis by age group, on the right, we see that the increased diagnoses occurred mainly in individuals aged 20 to 29 and 30 to 39 years. and injection and other illicit drug use was reported as the primary risk factor. In fact, the rates of acute hepatitis C virus infection among young suburban and rural persons who inject drugs in Indiana, including Scott County, and across much of the Midwest and Appalachia, has increased significantly between 2006 and 2012. And those increases, you might say, foreshadowed the Scott County HIV outbreak. Next slide, please. The HIV outbreak really increased public awareness of injection drug use as a risk factor for HIV and hepatitis C transmission. During the outbreak, there was a significant effort to deliver testing services for both HIV and Hep C to those at risk in the places where they were likely to go, like emergency departments, addiction treatment centers, doctors' offices, jails, and in their own homes. The accessibility of testing really allowed us to rapidly identify individuals with HIV and Hep C and provide linkage to care. In addition, genetic testing and analysis of HIV done by our partners at the CDC estimated that by the date of the first HIV diagnosis in late 2014, 4 out of 10 persons who would later receive a diagnosis of HIV were already seropositive. The peak on the Scott County hepatitis C infection curve on this slide occurred in 2015 at the height of the HIV outbreak response. This curve, though, increases annually prior to the outbreak, and that reflects a similar pattern of ongoing transmission during the years leading up to the outbreak. The surge in HCV diagnosis in 2015 mostly represents delayed identification of individuals previously infected and highlights the really important initiatives to test individuals where they are likely to be. Next slide, please. I can't overstate the importance of community engagement and community-based services during the response in Scott County. County healthcare providers and officials worked with state government to authorize and create the first legal syringe services program in Indiana. This program established a model for providing care that has become the standard for other syringe services programs in the state. The syringe service program provides clean injection supplies, but they also provide harm reduction education, naloxone and naloxone education, immunizations, health care, referral to addiction treatment, clothing, food, TB testing, and they link people to registration for our HIP 2.0 alternative to Medicaid expansion here in the state of Indiana. Over half of participants interviewed during a study of people who inject drugs in Scott County reported that they received their last HIV test at the syringe services program. So they are accessing for more than just syringes. Study participants with HIV who used the syringe services program indicated that they had dramatically changed their injection practices. Before the syringe services program, 90% reported sharing needles, but after the syringe services began offering services, less than 10% reported any sharing, and qualitative data that we have suggests that those with HIV who continued to share did so only with others who had already been diagnosed with HIV. Linking those individuals diagnosed with HIV and or Hep C to care was equally critical during the outbreak response, so we could reduce the reservoir of virus in the community and reduce ongoing transmission. There were no infectious disease physicians in Scott County, but Dr. Will Cook, the primary care physician in Austin, enrolled in an HIV hepatitis C ECHO project. ECHO, or Extending Community Healthcare Outcomes, is an evidence-based model where experts in complex medical care work with providers in underserved communities to share knowledge during case-based learning. Dr. Cook became proficient in providing expert care to those in the community with HIV and hepatitis C, and as the care continuum graph on your right demonstrates, the community-based model was truly a success for providing care to a population with substance use disorder that many told us were difficult to treat and couldn't be done. All individuals with HIV in the community are engaged in care. Nearly 75%, as indicated on the far right bar, of those who have been linked to care have achieved and maintained viral suppression, a rate which is nearly twice the national average. Next slide, please. This final graphic illustrates, I believe, one of the most compelling outcomes of the community-based services, including harm reduction and enhanced access to testing and treatment for people who inject drugs. In 2016, LifeSpring, which is the Community Mental Health Center in Scott County, co-located mental and behavioral health services and addiction treatment services with the syringe services program. The federal relaxation of the buprenorphine treatment limits actually subsequently increased capacity for treatment at the site. And for the first time, treatment for addiction was accessible in Austin, Indiana. Self-referrals and referrals from the medical provider, the syringe services program, and the jail led to a dramatic increase in the number of people enrolling in addiction treatment, and that's represented by the light blue bars. Anecdotally, we've heard that getting into treatment is really now the thing to do in this community. The green line represents daily numbers of syringes needed by clients. Once at-risk injection behaviors in the community were identified, the syringe service program staff learned to accurately assess syringe use and needs, and that happened early in 2015. Since 2015, there has been no increase in the average daily number of syringes needed by clients. The combination of increased awareness of HIV, hepatitis C, and their transmission risks, the increased accessibility of testing, the availability of clean injection supplies in a non-stigmatizing setting, access to care for HIV and hepatitis C in the community, and now access to medication-assisted treatment have all played an important role in reducing the ongoing transmission of HIV in this community, as is evidenced by that red line trending towards 0 new HIV infections in the last half of 2017. I will end there, and thank you very much.
Thank you so much, Joan, as well as Christi, for giving us the overview, for reviewing what has been effective in really a critical situation that you found yourself. It's wonderful to hear the stories from that experience, and really appreciate your sharing.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.